Good afternoon, everybody, and welcome to this webinar. And today we will be discussing multiple myeloma and Waldenstrom Macroglobulinemia. Now, multiple myeloma is a plasma cell neoplasm, and nowadays at many centers and even WHO now calls it as plasma cell neoplasms. However, whenever we talk of plasma cells, what we say is plasma cell proliferations like lymphoid proliferation, similarly plasma cell proliferations, which may be reactive or it may be neoplastic. Reactive, we know in many chronic diseases, the plasma cells increase in number. Neoplastic is what we call as multiple myeloma or plasma cell neoplasm. This is a term now used by WHO, which says it is a neoplastic clonal proliferation of plasma cells. The most important word in this is clonal. Now, how do we know whether multiple myeloma is clonal or not? Because the very definition is clonal proliferation of plasma cells. So that means if we say multiple myeloma or plasma cell neoplasm, we have to prove that the proliferation is clonal. Now we know that there is secretion of M protein, and which is usually of IgG type, but the light chain could be either, it could be kappa or lambda. Now, suppose it is a reactive plasma cell proliferation, and then we will find that nearly half the cells will show kappa light chain, another half will show lambda light chain. If it is clonal, that means all those neoplastic plasma cells will demonstrate either kappa or lambda. So that means in any case, if we want to say that this particular case belongs to multiple myeloma or it is a plasma cell proliferation is neoplastic, we must prove that it is either kappa or lambda. Second is, these neoplasms are also associated with production of monoclonal immunoglobulin. That is what it means, that all of them will be either kappa or lambda. Now, this is what we label as M protein, or later on we will talk about M spike. Now, what happens is, say this is the hematopoietic stem cell, and this is a normal differentiation of a hematopoietic stem cell, say of the first T or B, then we take B cell proliferation, then it finally differentiates into plasma cells. And these are the normal plasma cells which are present in the bone marrow, and they have come actually from the lymphoid cells. Now these plasma cells, they lead to secretion of antibodies depending upon the antigen, the bacteria, virus entering the body, and the antibodies are formed. Now these antibodies, as you can see, are of multiple colors, indicating that some could be IgG, some could be IgA, and then also some could be kappa, some could be lambda. On the other hand, suppose this plasma cell becomes neoplastic, there will again be proliferation of the plasma cells, but these plasma cells will be clonal. That means they will produce even the immunoglobulins of similar type. Say they are producing IgG, then all of them will be IgG. All of them will show the light chain will be either kappa or lambda. So this protein which is secreted, what we call as M protein. But this M does not have any correlation with IgM, which we will talk about when we talk of Waldenstrom Macroglobulinemia. Now this is the process of initiation. You can see the post-germinal center B cell. It gives rise to MGUS, that is monoclonal gammopathy of unknown significance, which is a precursor of multiple myeloma. In between the two, there is a stage, what we label as smoldering myeloma. And finally, there is multiple myeloma, and this myeloma may go on to even plasma cell leukemia. Another thing is, the disease started from the germinal center of a lymphoid follicle, maybe in the lymph node, MGUS, smoldering myeloma we diagnose in the bone marrow. And then these plasma cells, they come into the peripheral blood. Once we see them in the peripheral blood, we label them as plasma cell leukemia. So how do we diagnose a case of multiple myeloma? What is must is evaluation of the clinical burden of plasma cell infiltration, that how many plasma cells are there and what is the effect clinically. Second is radiographic analysis of bone lesions. As you can see here in this skull, even in the long bones, you are seeing lytic lesions all over. Multiple lytic lesions you find in clavicle, you find in ribs, you find in skull, mainly in the flat bones. And then we have electrophoretic determination of monoclonal immunoglobulin. Now what I am showing here is actually not a monoclonal immunoglobulin, but it is plain and simple serum electrophoresis, where this is albumin. The first dark band is albumin. Then these are beta 1, beta 2, alpha 1, alpha 2 globulins. And finally, in the gamma region, you can see a peak. Now, this peak is actually the secretion of gamma globulin of IgG type usually. And this is what we see, a dark band. This is M protein. Now, how to diagnose multiple myeloma for the burden of plasma cells is we have to do a bone marrow aspiration along with a refined biopsy to make a diagnosis and assess how many plasma cells are present in the bone marrow. When we were students, we were taught Salmon and Dury criteria for diagnosis of multiple myeloma. The major criteria was plasmacytoman biopsy with a bone marrow plasmacytosis of more than 30%. And then M band in the serum, that is of IgG type, it should be more than 3.5 grams. IgA should be more than 2 grams, and urinary light chain excretion. These were the major three criteria. And the minor criteria were plasmacytosis when it was less than 30%, that is 10 to 30%. And the IgG, IgA, which is monoclonal, is also less than 3.5 and also less than 2 gram. Lytic bone lesions should be there. And then this is the normal ratio, normal amount of these immunoglobulins given. So at that time, the criteria for diagnosis was 1 major and 1 minor, or 3 minor criteria, which must include 1 and 2. That means there must be plasmacytosis in the range of 10 to 30%. And second is there should be monoclonal globulin spike. Things have changed now. In 2015, which is the latest one, as far as multiple myeloma is concerned, International Myeloma Working Group has been working, say, for last 20 years. And whatever criteria they are giving, everybody is following those criteria all over the world. And now they say that the new definition of active multiple myeloma is clonal bone marrow plasma cells, which should be more than 10%. See, Salmon Dury said more than 30%, but this says more than 10%. But then the plasma cells should be clonal, or there could be an extramedullary plasmacytoma. Second is 1 or more of the Crab features. Now I'll tell you what the Crab features are. 1 or more. And second is 1 or more of the myeloma defining events or the biological markers of malignancy. Now this is something new which IMWG has added. And with this, what has happened is the diagnosis of multiple myeloma has become easy. One can easily diagnose because the criteria are very well defined. Now, what are the criteria? We will go to them. CRAB. Now, what is this CRAB? Evidence of end organ damage. That means the end organ damage has to be by the plasma cells. Now, C of the CRAB is for hypercalcemia. That is more than 11 milligram. Renal insufficiency, R. Creatinine clearance is less than 40 ml, and serum creatinine is more than 2 milligram. Then we have anemia of CRAB. Hemoglobin is less than 10 grams. And then we have B of CRAB, bone lesions. It should be 1 or more osteolytic lesions on skeletal radiography or on CT or on PET-CT. Now, sometimes we say here that the plasma cells should be more than 10%. and then they have to be clonal, which I told you that either kappa or lambda. But sometimes, suppose the bone marrow plasma cells are less than 10%, then more than one bone lesion is required to distinguish from solitary plasmacytoma with minimal marrow involvement. This is in case we have a patient who has got plasmacytoma and the plasma cells which are clonal are less than 10%. Is it myeloma or not? Then what we have to have is more than one bone lesion along with, of course, the plasmacytoma. Then it should be at least one myeloma defining events in a patient, or what we call as biological markers, biomarkers of malignancy, any one or more of the following biomarkers of malignancy. Now these are 60% or greater clonal plasma cells on bone marrow examination. Now 60% or greater, but they have to be clonal. Now suppose we have got bone marrow aspirate, we have got bone marrow biopsy also, and then we find that on the aspirate the cells are only 20%, plasma cells are 20% because the marrow is diluted. On the other hand, we have the biopsy, we can do CD138 and count the number of plasma cells. So whichever is higher, that is taken as the number of plasma cells. Second is that this definition has also taken into account free light chain ratio, that is kappa is to lambda. Now serum involved upon uninvolved marrow. Suppose we have got a kappa light chain type of myeloma, that is a IgG type of myeloma in which the clonality is kappa. So serum involved, that means kappa, upon uninvolved, that is lambda. So the amount of involved free light chain assay upon uninvolved should be more than 100. Say here it is 500, the serum 500 milligram, here it is 4 milligram only. So 500 divided by 4, it is 125. It is greater than 100. So serum free light chain ratio of 100 is very, very important, not only for diagnosis, but also for prognosis. And once we give the treatment, to see the response to the treatment, because we go by how much free light chain ratio is changing, which light chain is increasing, which one is decreasing. And more than one focal lesion on MRI. Now that is also important, but it should be at least 5 millimeter or greater in size. Now what is important is that these are three markers or myeloma defining events. The presence of at least one of these biomarkers is considered sufficient for a diagnosis of multiple myeloma, even if CRAB features are not there. So that means these have much more importance than the CRAB features. Earlier we used to take CRAB features into account, but now what we take into account is myeloma defining events. One of them only that is good enough for us to diagnose a case as multiple myeloma. Then comes clonality of plasma cells, because the definition is based on clonal plasma cells. So how do we establish? That means what we say is light chain restriction. As I told you, that the myeloma will be either of kappa or of lambda. Now how do we know that which light chain restriction? Either by flow cytometry of the bone marrow aspirate or by immunohistochemistry on the bone marrow biopsy. Now we have got anti-kappa light chain, we have got anti-lambda. So we apply the immunohistochemistry like you do for other markers, and you do that. Third is immunofluorescence. Now which ones are more commonly used? Both of them, flow and immunohistochemistry. These are extensively used for establishing the clonality. Now what will happen on immunohistochemistry on flow? That all the neoplastic plasma cells will be either kappa positive or they will be lambda positive. Now suppose we have a patient in which the plasma cells are less than 10%. Then what we require is more than one lesion on radiography to distinguish it from solitary plasmacytoma. Now this is what we call as clonality of plasma cells. Say these are the clusters of plasma cells on bone marrow trephine biopsy. So what we have done here is CD138. Now the two markers which we commonly use for on flow as well as on immunohistochemistry is CD38 and CD138. Here you can see it is CD138 because we found that CD138, the myeloma cells or the plasma cells are very well made out. So we prefer CD138. Now you can see here the number of plasma cells was increased, but we didn't know how much. Now here we have all these plasma cells. You can count the other nuclei, count these plasma cells, and give what is the exact number of plasma cells. Obviously, it is more than 40% plasma cells are present. Now, but we can't say these are clonal. So what we have to do is apply anti-kappa and anti-lambda. So what we have done is we have applied anti-kappa and anti-lambda on the same case. Here what do you find? On kappa, you find all these plasma cells are positive. It is cytoplasmic positivity. Anti-lambda is negative. So that means the plasma cells are clonal. So therefore, this will be regarded as a case of plasma cell neoplasm. Serum free light chain assay. Now, free light chains are not bound to heavy chains. Say, now we know that these are the heavy chains, these are the light chains. If they are not bound to the heavy chains, what we label them as serum free light chain. Now, these are of two types, kappa and lambda, and the normal ratio is kappa upon lambda 0.26 to 1.65. So around about 1 plus minus 0.75, that is the normal kappa upon lambda ratio. Now, clonal free light chains will be produced by the neoplastic plasma cells. Since they produce only kappa, so what is going to happen is kappa amount will increase in hundreds, lambda will remain the same or it may decrease. So the kappa is 500, lambda is 4, the ratio becomes 1.25. But one condition IMWG has put up that the free light chain product produced should be more than 100 milligram per liter. Suppose it is 40 milligram kappa, it is 2 milligram lambda, ratio is 20, we will not consider into account as myeloma. Free light chain produced should be more than 100 milligram. Okay. Suppose we have a case of smoldering multiple myeloma, which is a precursor of multiple myeloma, and this ratio of kappa upon lambda is more than 100. This indicates that this patient will very immediately or very in a few weeks will go or progress from smoldering myeloma to multiple myeloma or overt multiple myeloma. However, many of the cases of myeloma, they have renal impairment, and it is recommended that then we should consider kappa lambda ratio with a modified range of 0.37 to 3.1 rather than 0.26 to 1.65. Now, what do we find on the peripheral blood? Now, since the gamma globulins are increased or the M protein is present, it causes rouleau formation. You can see the rouleau. The red cells are in as if they are in stakes of coins. And then you find that the background staining is there. This is a plasma which is stained because of the high globulin content. So background staining, and then you find these rouleau formation that is highly suggestive of a case of hypercalcemia. It will not indicate it is myeloma. But if we find plasma cells in the peripheral blood, then we will label it as plasma cell leukemia. Of course, the number should be more than 1,000 or so. Then bone marrow. Now, what do we find on the bone marrow? In the bone marrow aspirate or in the imprint smears, we always count the number of plasma cells because it is count of the bone marrow cells whenever we count. Here you find 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 plasma cells, say out of about 30 or 20 cells. So that means these are more than 10%. So if they are more than 10% and if they are clonal, it is likely to be a case of multiple myeloma. Now what happens? As you find here, the plasma cells, as their number keeps on increasing, sometimes we come across as high as 90-95% plasma cells in the bone marrow. What is happening to the myelopoiesis? It keeps on decreasing. What happens to erythropoiesis? Erythroid cells are also diminishing. Megakaryocytes are also diminishing. So sometimes the patient comes to us with pancytopenia, though the patient is a case of multiple myeloma, and these are plasma cells which are present in the bone marrow. See the lower picture here, almost except for 2 or 3 cells, rest of the cells are all plasma cells. Now, one thing we have to keep in mind is that these plasma cells, they usually have a perinuclear half if they are of mature type. Immature plasma cells or plasma blasts may not show this perinuclear half. Cytoplasm is usually basophilic, provided the pH of the ginger stain with which you are using, that is 6.8, so that then you can appreciate the perinuclear half and the basophilia of the cytoplasm. Whenever we are examining a bone marrow, you will find that in the cytoplasm, we find immunoglobulins. Now, these are Russell bodies. As you can see, these immunoglobulin, these are the Russell bodies. These are in a plasma cell, which plasma cell keeps on secreting these immunoglobulins. Now, such cells are known as Mott cells, morula cells, or the grape cells. See, it is the extracellular also, which is lying around. Then we also find that in some cases, you will come across intranuclear inclusions. These are known as Dutcher bodies. As you can see, this pink intranuclear inclusion. Here also pink intranuclear inclusion in the nucleus. Here also, and these are again. See, whenever we find intranuclear inclusions like Dutcher bodies, usually such cases belong to multiple myeloma rather than reactive plasmacytosis. Then the derangements in the immunoglobulin secretion. We find multiple shapes and sizes of the plasma cells, number one. Number two, we find a differentiation, which is say from mature to plasma blast. And then we find, say, cells like this. Here you find that these plasma cells, they are flame shaped. Now, like it is something like flame shaped, what we find in thyrotoxicosis, whenever you do FNEC, of where we say that the flame cells are present. What you find is that the peripheral part of these plasma cells is red in color. And this is the what we call as a fire flare appearance. So these are known as flame cells. Flame cells are more common whenever we have a case of IgA myeloma. Then we also come across fine granular cytoplasm, fine vacuolation cytoplasm, and then we also find rod-like inclusions, fibrillary inclusions. These are all inclusions which are present in the cytoplasm of these myeloma cells. Then we find in some of the myeloma cells, say these are immature myeloma cells, you can see the nucleolus, but in the cytoplasm you can find crystalline material. So crystalline inclusions, you find fibrillary inclusions, round inclusions, fire flare appearance or flame-shaped cells. These are all features of plasma cells which are seen in this, in a case of multiple myeloma. Another thing we come across is pseudo-Gaucher cells. Now, pseudo-Gaucher cells are like Gaucher cells. As you can see here, they look like Gaucher cells only. Nucleus is eccentric, lot of cytoplasm. These are macrophages. And these actually, whenever there is a high bone marrow turnover, say for example, in a case of CML, or in a case of multiple myeloma, or in a case of thalassemia, see the cells are dying. So what happens is the sphingolipids are released, which are picked up by these macrophages, and they give an appearance of pseudo-Gaucher cells, but these are macrophages. Now you can see in this picture 1, 2, 3, 4, 5. These are pseudo-Gaucher cells which are present. Now in this case, what happened was, what we got was in the aspirate mainly these pseudo-Gaucher cells, but the man was 70 years old. So we knew that these are not Gaucher cells. These are likely to be pseudo-Gaucher cells. But then in that aspirate, the plasma cells were only about 10%. Then we stained rest of the slides. Then we got the bone marrow fine biopsy, in which we found that the disease is not of these pseudo-Gaucher cells, but the disease is the neoplastic plasma cells. The neoplastic plasma cells were responsible for the formation of pseudo-Gaucher cells. And then that these are pseudo-Gaucher cells, we confirmed with a CD68 stain, which stains the macrophages. Then Grip et al. From Mayo Clinic, he devised a plasma cell grading system. That is, whenever we come across plasma cells, whether those are well differentiated, mature type or not, so they subclassified into 4 or 5 subtypes. See, one is mature type, which we label as plasmacytic. They look like normal plasma cells, as you can see, perinuclear hop, basophilic cytoplasm, no nuclei, no nucleoli, and this is the normal looking plasma cells. The only thing is these are increased. So these are mature type. Even on the bone marrow section, you find that these are sheets of these plasma cells. Obviously, the number is much more than 60%. Maybe say 90, 95% this field only. So, and we know that the more than 60% of the plasma cells is highly suggestive of multiple myeloma. So this is the mature type or the plasmacytic type. Then we have the immature type. We call it immature if the plasma cells are large, as you can see here to the previous picture. Nuclear chromatin is slightly more open than that of a plasma cell. No cartwheel appearance is seen, and then you find each cell has got a nucleolus. So nucleolus is essential to label a plasma cell neoplasm as immature type. Why do we want to differentiate one from the other is that the mature type has a better prognosis as compared to the immature type. Immature type has better prognosis as compared to the plasmablastic type. Now this is on bone marrow trephine biopsy. Now sometimes we don't get the bone marrow aspirate at all. We get bone marrow trephine biopsy. And in this trephine biopsy, what we are looking at some amount of cytoplasm which is eccentric, and then you find nuclear eccentric, and then each cell has got nucleoli, prominent nucleoli. Now that gives us an idea that since the nucleus is eccentric, we have the imprint that we are dealing with a case of immature type of plasma cell myeloma. Then we have intermediate type, that is in between mature plasma cell and immature plasma cell. Here there are no nucleoli. Chromatin is slightly more open as compared to a plasma cell, less open as compared to immature. Here you don't find the nucleoli, but the cells are slightly larger and chromocenters are seen. So this is intermediate type of myeloma. And then we have plasmablastic type. Now these are the plasmablastic type. Now see here. Here the first thing, the cells are not, nuclei are not eccentric, number one. Number two, chromatin is open. Number three, you can see prominent nucleoli which may be more than one, 2, 3. You may find two nucleoli, you may find three, you may find one nucleoli. Then the nucleus is central in these cases of plasmablastic. Like any other blast, the only thing is cytoplasm is much more than say that of a myeloblast or a lymphoblast. Actually, such cells resemble a little bit of monoblast, which have got more cytoplasm. Now, if we don't find such cells, but we find we have a bone marrow trephine biopsy, so what do we find? What you are seeing is only the blast cells. Nucleoli, central nuclei. We cannot say that these cells are plasmablasts. And sometimes we may confuse them with a blast cell, or we may say that these are lymphoblasts. So we keep on putting up markers for lymphoblasts. We keep on putting up markers for myeloblasts, thinking that it is a case of acute leukemia. But no, it is not acute leukemia. It is not lymphoma. It is a plasmablastic type of myeloma. The moment you do CD138, it comes positive. You do kappa lambda, these are clonal, and then we diagnose as a case of multiple myeloma, plasmablastic type. Now, GRIP says that in a bone marrow aspirate or in a biopsy, if you find more than 2% plasmablasts in the marrow, only more than 2%, say 5%, 10%, that means the prognosis becomes adverse, and it is an independent adverse prognostic factor of plasmablastic type. And then we have the pleomorphic type. Now, this is what the pleomorphic type is, all shapes and sizes of the plasma cells. You cannot say that these are plasma cells. You will say it is an anaplastic type of tumor if I don't tell you that it is from the bone marrow or not. And this is the bone marrow trephine biopsy. See, when this came, this biopsy, I reported it as they wanted urgent report. I said it looks more like metastatic pleomorphic carcinoma. Which carcinoma I can't say. Now it was later on when we put all the various markers, cytokeratin, EMA and so on, and kept on trying, everything negative. Then we stained some more smears of the bone marrow aspirate, and then we found that there were some cells in which the nuclei were eccentric and they gave a plasmacytoid appearance. We put up CD138 and lo, all the cells came out to be positive. So we come across, whenever in the bone marrow you find a pleomorphic picture, either it is metastatic carcinoma or it is a pleomorphic multiple myeloma, and incidentally both of them will present as multiple lytic lesions. Now why should we do a trephine biopsy in multiple myeloma? Whenever the bone marrow is inadequate, aspirate is inadequate. Why is it inadequate? Because there is fibrosis of the marrow or there is amyloid. See, because if there is amyloid, the needle hits the amyloid, you don't get anything in the aspirate. And then you want to know that this could be myeloma. If that is so, is it diffuse? Because if it is diffuse, that means the hemopoietic elements are replaced and there will be pancytopenia. Then why should we do trephine biopsies? You can do immunohistochemistry. You can put up 138 kappa, lambda, CK, etc. every marker and confirm that we are dealing with a case of multiple myeloma because the cells are cloned. And then, then for assessment of hemopoietic reserve. And whenever to assess angiogenesis, like in cases of multiple myeloma, the angiogenesis increases. And then whenever we have a suspected multiple myeloma clinically or a case of AMGUS or smoldering multiple myeloma. Now, why aspirate is non-diagnostic in 10 to 15% of the cases? Now, myeloma is one disease. We should always keep in mind that the disease begins with small patches in the bone marrow. Suppose you have got a bone marrow biopsy and it is an early case. You may find 4 or 5 nodules or aggregates of plasma cells. That's all. And if you do an aspirate, the needle may not hit that tiny aggregate of 20 cells. So you will not come across plasmacytosis. So you may feel there is no plasmacytosis, so it is not multiple myeloma. The disease is patchy to begin with, and it remains patchy for many years to come. So therefore, biopsy is essential because on biopsy you will find a few patches, then you will do 138, there are plasma cells, then you will confirm with kappa lambda. So the nodular infiltrates, focal deposits, early disease, all of them can be seen on bone marrow biopsy. Then we have the infiltration patterns. Is it interstitial? Is it nodular? Is it diffuse, sheet-like, solid, or mixed? Let's see. See, this is interstitial. Where are you finding these plasma cells? These are interstitial. In between the other hemopoietic cells of the marrow. Megakaryocytes, some dark staining erythroid precursors, and in between you will find these creeping plasma cells are present. Here these are erythroid precursors. So it is interstitial. Then there may be nodules, as you can see here, a nodular deposit of multiple myeloma. Here you find that the total marrow is replaced by sheets of plasma cells. It is diffuse. Now these are the patients in whom hemopoietic reserve is not present. There are no myelopoiesis, no erythropoiesis, no megakaryopoiesis. So these patients develop pancytopenia. Mixed is that you find aggregates of plasma cells and you also find interstitial infiltrate amongst the other hemopoietic cells. That is a mixed pattern of multiple myeloma. Now sometimes we come across amyloidosis which is associated with multiple myeloma. What you find first thing is it multiple myeloma? We are finding here sheets of plasma cells and it appears that these plasma cells are around or they are secreting this pinkish material which is the amyloid. So what we do is we do Congo red staining, see under polarized light and look for apple green birefringence. Even with Congo red stain, the amyloid deposit comes red in color. Now, another thing we have to keep in mind is that about 25 to 30% of the cases of multiple myeloma are associated with bone marrow fibrosis. As you can see here, there is a streaming of the cells. There is increased reticulin streaming of the cells. If you put in a needle, you don't get a good aspirate because there is fibrosis of the marrow. So on triphyine biopsy, you find this, do CD138 and confirm. This is bone marrow necrosis. See here, there is extensive bone marrow necrosis, but few cells are seen like this, which is suggestive of multiple myeloma. So what we do in such cases is, if the whole marrow is showing necrosis, then what we do is take multiple cuts or multiple sections. In deeper tissue, sometimes we come across some viable foci of the cells, and we find that the plasma cells are present, and then confirm the diagnosis of multiple myeloma. So again, multiple myeloma fibrosis. So what we have done is 138, it is positive, kappa is negative. Here the lambda is positive in all the plasma cells. So we know that it is clonal plasmacytosis. So it is a case of multiple myeloma. So what is the role of immunohistochemistry? Number one is identification and quantification. How many plasma cells are present? Because aspirate may be a dry tap because of marrow necrosis or because of marrow fibrosis, or it may be a faulty technique. So what we do is we do CD38, CD138. About 2/3 of the cases are CD56 positive also. About nearly 2/3 to 3/4 of the cases, they are also positive. And that is an indication of malignancy. Second, the most important role of immunohistochemistry is to demonstrate clonality. That is, either it is kappa or lambda. So we do immunohistochemistry to confirm that. Then we can do other prognostic markers like CD56, cyclin D1 is associated with a better prognosis. The bad prognostic markers are P53, CD44, FGFR3 and CD28. So immunohistochemistry has a great role in diagnosis by showing us the clonality and sometimes quantification of the myeloma cells and identification. See, sometimes we find that there is 100% cellularity of the bone marrow. You can't make out how many are plasma cells. There are erythroid cells, there are myeloid cells. So just do CD138 and it will give us an idea about the number of plasma cells. So what are the prognostic parameters on bone marrow examination? Pattern of marrow infiltration. If it is nodular, it is a comparatively less aggressive disease. It should be less aggressive disease. Diffuse or packed marrow, it is a worse disease, worse prognosis. Morphology, if it is plasmablastic, it is associated with a worse prognosis. Plasma cell labeling index, earlier it was done, but nowadays it is not carried out. Angiogenesis was carried out to see the disease progression and activity. Now it is not done. Now we do CD20. Now there are some variants of CD20 positive, especially the lymphocytic type, which carry a better prognosis. Fibrosis in the multiple myeloma is associated with a poor prognosis. Then we go on to plasma cell leukemia. Now what is plasma cell leukemia? This is a peripheral smear and you find 1, 2, 3, 4 plasma cells are present. Presence of more than 20% plasma cells in the peripheral blood or absolute plasma cell count more than 2000. Either of the two, or usually both are associated with each other. And then we find that in these cases, usually the diffuse infiltration of the bone marrow occurs by the plasma cells. And sometimes whenever there is a plasma cell leukemia, CD56 becomes negative, because what happens is that CD56 actually binds the plasma cell to the stroma. Since it is not bound to the stroma, they are coming into the peripheral blood. That is because they lack CD56. And such cases of plasma cell leukemia, they have an aggressive course. And moreover, plasma cell leukemia may be de novo. That is, the disease may arise as plasma cell leukemia only. Or sometimes we find that it is a case of multiple myeloma, started as multiple myeloma, started as a say focal deposit, then gradually it involved part of the marrow, then it involved the diffuse pattern, and then the plasma cells, they spill into the peripheral blood, and then we find plasma cell leukemia. Now, as I told you in the very beginning, that it is associated with secretion of gamma globulin and what we label as M spike or M protein. Now, this is a usual normal serum protein electrophoresis. That is what we have done is we have taken serum and done the electrophoresis. Major part, this is albumin. And then we have alpha 1, alpha 2, beta 1, beta 2. And then this is a gamma globulin. Now we keep on saying that the gamma globulins are increased. That means this is the normal gamma globulin. The amount is 16.1% or 11 to 18%, and per gram per deciliter it is 0.8 to 1.4. Albumin, of course, is the highest, which is about 3.5 to 5.2 gram. So this is albumin, alpha 1, alpha 2, beta 1, and this is the gamma globulin. Now what we always say is AG ratio. We calculate the globulin upon say albumin upon globulin AG ratio, so which comes to 1.36 in this particular case, which is normal serum protein electrophoresis, and that is the normal ratio. Now this is another case. What we find here is albumin is normal, and then we have alpha 1, alpha 2, we have beta 1, beta 2, and this is a gamma. Here we find a protein which has surpassed even the albumin. So that means what is the amount of this protein is, it is 37% in this particular case. And what we find here is on electrophoresis, this is a spike we are seeing. We call it as M band or M spike, but actually it is a gamma globulin. Now what is the nature of this? Usually in 80 to 90% of the cases, it is IgG type. Few cases are IgA, still few cases are IgD. Rare cases are IgM, and then we have to differentiate that from Waldenstrom Macroglobulinemia. So this is the M spike. Then we also want to know whether it is IgG type, whether it is of kappa, whether it is of lambda. Because in a patient, today we do a basic parameter. These are the basic parameters for multiple myeloma. So what has happened is this we call as immunofixation electrophoresis, IFE. Now this should be carried out in each case. Like I said, serum free light chain ratio or the serum free light chain assay must be carried out in all cases these days, which is not only diagnostic, but we can assess the prognosis. We can follow up those cases that how they are responding to treatment. So what do we find here on immunofixation electrophoresis? It is gamma chain is positive. That means it is IgG. A is negative, M is negative. Out of then light chains, we have kappa or lambda. It has to be clonal. So what we find, lambda is nil, kappa is the only chain which is present. So what we have is IgG kappa type. Now that means if we are doing immunohistochemistry or if we're doing flow cytometry, then the plasma cells should demonstrate kappa positivity. And later on, whenever we are following up those cases, following treatment, what is happening is we should assess IgG and then we should assess the kappa type, because this is what we know this patient is having. Now this is another patient, and what we find here, the major protein here is A. A is the alpha, that is IgA. So here in this particular case, there was M spike, but that M spike belonged to IgA. Out of kappa lambda, it was only the lambda which was present. So we have a case here of A lambda type. So depending upon kappa lambda, one light chain has to be there clonal, and then out of G and M. Now why we have not included D and E? Because D is uncommon and E is still rare type of myeloma which we come across. Now we all know that nowadays, say after acute leukemias, the lymphomas and the multiple myelomas, now we are studying the molecular markers in all these cases and to know what is going to be the prognosis, whether there are trisomies, where there are deletions, where there are translocations, and in some cases, these are the kits are available. You can do by FISH method in more than 90% of the cases. Now, what is the IMWJ consensus on genetic testing? They say that in every case, we should put up a minimal panel of 3, which is that T414, T1416, and deletion 17p. More comprehensive panel should include 4 more, that is T1114, deletion 13, ploidy category, and chromosomal 1 abnormalities. Now you will find that most of the translocations, 414, 1416, 1114, chromosome 14 is involved because there is a defect in the IGH secretion. So IGH gene is on chromosome 14q32. So that is why you will find that the 14 chromosome is involved, and these abnormalities are present in 55 to 75% cases of plasma cell myeloma. Now, which ones are standard risk, which one are intermediate risk, and which one are the high risk? Because if we are doing that, what we are trying to assess is the prognosis. Standard risk is 1114, 614, and hyperdiploid, and all others. But if we have intermediate risk, that means 414, deletion 13, and hypodiploid. Here the overall survival is 4 to 5 years. While in the standard risk, it is very good survival, 8 to 10 years. But if we have a case of high risk, then deletion 17p, T1416, T1420. So these are the ones, any of them positive is a high risk case. Overall survival in such cases is only 3 years. So which ones are more? See, the standard risk cases constitute a big chunk, 60%, intermediate 20%, high risk 20%. Then we go on to other plasma cell disorders. Others, what we have done is on way to becoming myeloma. One is MGUS and the second is smoldering myeloma. So it is a B cell proliferation which will go on to MGUS, and then it will go on to myeloma, smoldering, and then finally into myeloma. So what is MGUS? Now MGUS is that this is a precursor of multiple myeloma. The disease starts as myeloma of unknown significance or myelogammopathy, and there is an expansion of plasma cell proliferation, and it is a precursor of multiple myeloma, and there is a high risk of progression of smoldering myeloma to multiple myeloma. But MGUS takes, say, it is a slow growing disease, and what we find is 0.6 to 3% per year of these cases will go on to multiple myeloma. On the other hand, smoldering multiple myeloma, 10% of the cases will go on to multiple myeloma per year. So if we have a population study, it is present in 2% of the population. Criteria for diagnosis. Now that is most important for us as a pathologist. Bone marrow plasma cells less than 10%. Clonal. Now this is again important. They have to be clonal plasma cells less than 10%. Absence of CRAB. Now CRAB, we said, is part of the end organ damage like kidney, like anemia, bone marrow, bone abnormalities, and the renal insufficiency. So absence of CRAB. Because if there is CRAB, it becomes multiple myeloma. Clonal bone marrow plasma cells less than 10%, and serum monoclonal protein is less than 30 gram. Now these are the important 3 criteria for diagnosis of multiple myeloma. Majority of the MGUS is IgG type. Light chain MGUS is uncommon, but we do come across. IgM MGUS in Waldenstrom Macroglobulinemia is still uncommon. Then we have this light chain MGUS. Here we find that there is an abnormal free light chain ratio because it is a light chain MGUS. That means the immunoglobulin is not formed. It is only the free light chains which are increased. And since there is increased level of free light chains, so you find that this ratio gets altered 0.26 or 1.65. And there is no immunoglobulin heavy chain expression on immunofixation. Clonal bone marrow plasma cells less than 10%. Urinary monoclonal protein less than 500 milligram. Main thing is less than 10% clonal plasma cells. Now this goes on to smoldering multiple myeloma. Now we know it is the intermediate stage on the one hand between MGUS, on the other hand multiple myeloma, and the risk of progression I told you is pretty high. It is 10% per year, and 14% of all multiple myeloma cases are smoldering multiple myeloma. This was in a long-term study. Now there are two types of patients. One are those who have a low rate of progression, and there are others who have a high rate of progression to manifest multiple myeloma. But there is no single molecular marker by which we can say that this patient will have a low rate of progression or a high rate of progression. Both the criteria must be met for definition. This is the most important thing. First is monoclonal protein more than 30 grams or urinary monoclonal proteins more than 500 milligram per 24 hours, along with clonal bone marrow plasma cells in the range of 10 to 60%. They should be clonal. Absence of myeloma defining events, which I told you is now the criterion for diagnosis. Excuse me. And then absence of crab features, because when we talked about the diagnosis, we said crab feature, one of them, myeloma defining events, one of them. So both should be absent in smoldering multiple myeloma. Otherwise, the number of plasma cells could be same, 10 to 60% or more than 10%, and protein should be more than 30 grams per liter. Now this is a case of smoldering multiple myeloma. Normal looking bone marrow biopsy, we find one aggregate of plasma cells. Now this aggregate turned out to be positive on CD138, and not only that, it turned out to be only kappa positive. So that gave us an idea that we are dealing with a case of smoldering multiple myeloma. Then we did the serum free light chain assay, that was increased, and then we did the M protein assay, that was more than 30 grams. So that gave us an idea that we are dealing with a case of smoldering multiple myeloma. Now, whenever we have a case of plasma cell neoplasm, and every case may not show us all the features of multiple myeloma, there may be some cases in which we don't find all the typical features. So they have to be differentiated from reactive plasmacytosis, from plasmablastic lymphoma, from plasmacytoid immunoblasts of large DLBCL type, and then also from Waldenstrom Macroglobulinemia or a lymphoplasmacytic lymphoma in which there is secretion of IgM. Now in this case, there is hepatosplenomegaly as well as lymphadenopathy. Bony lesion, that is a lytic lesions, may not be seen, but diffuse osteoporosis is seen in these cases. So what is reactive plasmacytosis? We have already seen in various infections like Kala-Azar. I showed you the picture on the very first lecture. Metastatic deposit, aplastic anemia, chronic inflammatory disorders, sarcoid, cirrhosis. These are some of the common causes of plasmacytosis, which is reactive. So that means these plasma cells are not clonal. Some will be kappa positive, some will be lambda positive. So what happens in them? Usually the plasma cells are pericapillary on bone marrow biopsy. Plasma blasts are not encountered. Immature plasma cells are not encountered because they're not malignant. And then whenever you do kappa lambda, both are positive. So polyclonal is the plasmacytosis. Now this is the reactive plasmacytosis. Here we find we have done kappa and lambda. So kappa is positive in many of the plasma cells. Lambda is also positive in many of the plasma cells. So this is a case of typical case of reactive plasmacytosis in which some cells are kappa, some cells are lambda positive. Then we go on to the other disease entity. that is Waldenstrom Macroglobulinemia. Now, what we find in Waldenstrom Macroglobulinemia is the other name is lymphoplasmacytic lymphoma. And in this, there is secretion of IgM. M protein is there. M protein is for myeloma protein, but IgM is the nature of the immunoglobulin secreted. How do these patients present? These cases have hepatosplenomegaly, they have lymphadenopathy, they have thrombocytopenia, they have anemia, they may show us even pancytopenia. Then one of the most important clinical presentation is due to hyperviscosity. See, because of the presence of IgM, we find that there is hyperviscosity of the blood, and therefore it is difficult to make smears from this hyperviscous. And then we find there is blockage of the retinal vessels, there may be impairment of the vision. Sometimes it blocks in various capillaries and various organs. How do we make a diagnosis? First thing is that two things. One is more than 10% clonal lymphoplasmacytic cells in the bone marrow. That is number one. Second is demonstrate the secretion of IgM monoclonal protein. Third, which is now very, very important, is MYD88 L265P mutation. Now, this mutation is seen in nearly all cases. So far, by and large, most of the studies will show us that more than 90% of the cases demonstrate MYD88 mutation. So now we have three criteria: IgM secretion, more than 10% lymphoplasmacytic cells, and then we have MYD88. So what do we find on peripheral smear? Red cells are normocytic normochromic anemia is there. There is leukocytosis may be present, but it is less than. Now, why leukocytosis? Some of the lymphoplasmacytoid cells come into the peripheral smear, then the count increases and those cells are demonstrated. Second is thrombocytopenia. Now, this thrombocytopenia occurs later in course of the disease. Okay, so we have leukocytosis, anemia, and thrombocytopenia. So what do we find on bone marrow? Bone marrow, we find two types of cells. One is the lymphoid cells, and the second are the plasma cells. Now, what are these lymphoid cells? Now, these lymphoid cells are small lymphocytes. They are known as plasmacytoid lymphocytes, what we call them as P-lymphs. And often there are increased mast cells in the background. So what are these plasmacytoid lymphocytes? These are slightly larger than lymphocytes. They have an eccentric nucleus like a plasma cells, but the nucleus is not of a plasma cell, but it is of a lymphoid cell. So plasmacytoid lymphocytes admixed with plasma cells, and in the background we have mast cells. So they form a distinct clusters which is separate from the lymphoid cells. And what is the marrow involvement pattern? It may be nodular, interstitial, diffuse, and sometimes it is paratrabecular. Now these are the lymphoid cells we come across. Here you find that the cells are larger than lymphocytes. You find basophilic cytoplasm, and then you also find some of the cells are lymphoid-like, but here you are finding cytoplasmic vacuoles. Usually vacuoles are not seen, but few cases may show us cytoplasmic vacuoles, which may be because of the secretion of IgM. So these are the plasmacytoid lymphocytes, or P-lymphs, what we call them. Now this is on bone marrow biopsy, a diffuse involvement. The total marrow is replaced by sheets of these lymphoid cells. In between these lymphoid cells, you're finding some large cells with granular cytoplasm. These are sea blue histiocytes. See, sea blue histiocytes, as I told you, that pseudo-Gaucher cells or sea blue histiocytes are increased in various reactive conditions wherever there is a rapid turnover of the bone marrow. So sea blue histiocytes are seen. This is on hyper. What you find is sheets of these lymphoid cells, and in between you will find some scattered plasma cells are seen. Now what about the immunophenotyping? So if we have lymphoid cells, those lymphoid cells must demonstrate a surface IgM. That is important because these are the cells which secrete IgM. And then these are B cells. So CD19, 20, 22, 79A. These are all B cell markers which are positive. Then the markers which are negative are also important, like CD5, 10, 103, 23, so that all other lymphoproliferative disorders are ruled out. What about the intermingled plasma cells? They're of course CD138 positive, but not only that, they also express one B cell marker, that is CD19. So CD138 positive, CD19 positive, and of course the PAX5 positive. So these are the lymphoid cells and plasma cells. So in these cases, what we can do is we can demonstrate either by immunohistochemistry like here, or we can do a flow cytometric analysis of the bone marrow aspirate. So what we find here on immunohistochemistry, these cells are CD20 positive, since these are B cells, PAX5 positive, and then BCL2 also positive. And then the plasma cells. Now you can see the plasma cells are markedly increased in the bone marrow. This is CD138, but these all plasma cells are lambda negative and they are kappa positive, confirming the clonal nature of these P lymphs or plasmacytoid lymphocytes, and thus helping, and of course, secretion of IgM by these plasma cells, which is very, very important. That can be demonstrated by immunofixation electrophoresis. This is what the immunofixation is showing us. See, there is a very small band in IgG, but what we are finding is a dark band, very, very important band in IgM. So we have IgM here, and then it is kappa only positive, lambda negative, confirming the clonal nature or the clonal nature of these cells, which are secreting IgM of kappa type only. So what is the message is that we have to demonstrate plasma cells, or we have to demonstrate the P lymphs in the bone marrow in Waldenstrom should be more than 10%. Bone marrow refined biopsy is recommended not only for diagnosis, but in cases of marrow fibrosis, in cases of marrow necrosis, wherever the aspirate is not good enough, bone marrow biopsy should be carried out. And then we can perform immunohistochemistry on bone marrow refined biopsy, confirm the clonality, and then we should also now carry out serum free light chain assay and its ratio. Assay means more than 100 milligram. If it is if it is the involved free light chain, and then the ratio should be more. And then the plasmacytoid lymphocytes in an aspirate, they give a clue to the diagnosis of Waldenstrom's macroglobulinemia. So that is very, very important on morphology. And then we think on the lines of Waldenstrom, and then on the bone marrow biopsy or on bone marrow aspirate, we can get the immunohistochemistry or flow cytometry done and confirm the diagnosis of Waldenstrom macroglobulinemia. Thank you very much. We can take a few questions. This is a question from Dr. Swami, Mayuri Swami. She asks, do we have to give count of types of plasma cells in aspirate? No. Usually you will find in a particular case, majority of the cells are immature type, then majority are immature type, maybe some scattered mature plasma cells. If majority are mature plasma cells, then we may find few ones of intermediate. So you need not give the type of plasma cells, but yes, if you are looking at immature plasma cells or plasma blasts with prominent nucleoli, even if the number is low, you must mention that there are immature plasma cells, there are plasma blasts. It is likely to be a case of multiple myeloma. So you have to warn the clinician. Shiny, she asks how to assess percentage of plasma cells, that is CD138, in bone marrow biopsy. If only one marrow space showing sheets of CD138 positive cells, all other marrow spaces are showing normal maturation, can we say 100%? Yes, CD138 is a very good marker. See, even if there are 2 plasma cells and rest of the marrow, it will pick up those plasma cells. But whatever biopsy you have got, which is having say 100 cells and all of them are positive, so you will say that 100% plasma cells. But when you have to give the percentage of plasma cells, you will say that the rest of the marrow contains 500 cells. This plasma cells are 100%. So that means out of 600 cells, 100 are plasma cells. So the ratio percentage is 16%. So that means 16% plasma. We say percentage of plasma cells out of 100 cells of the marrow. If all of them are non-plasma cells, say 500 are non-plasma cells, fine. 500 are non-plasma cells, 100 are plasma cells. So that means out of 600, 100 are plasma cells. So the percentage is 16.6%. Dr. Chetna asks, plasma cells are counted as percentage against all nucleated cells, including erythroid myeloid. Yes, you are very correct. Dr. Shiny asks, how to distinguish bone marrow triphyine biopsy between immature plasma cells with nucleolus and plasma cells with intranuclear inclusion Dutcher body. Dutcher body is hyaline and it is pink in color because the biopsy section is H&E. However, you can find Dutcher body on bone marrow aspirate also. You will find the nucleolus you can easily make out. However, in a triphyine biopsy, the nucleolus is not rounded pinkish material, but it is a dark staining, or sometimes you find slightly eosinophilic nucleolus. If you look at 2 or 3 intranuclear inclusions, and then you will be able to pick up the next time when you see either inclusion Dutcher body or you look at the nucleoli, you will be able to appreciate. There is no problem. Is IHC a must in interstitial infiltration of plasma cells? Dr. Deepa. If you ask me, yes, it is essential. Because whenever there are plasma cells in an interstitial pattern, we cannot count them properly. Since we cannot count them, we underestimate them. But if you will do CD138, you will find the number is much more than we had imagined. So I always recommend that we must do CD138 in interstitial plasma cell infiltrate. Why there is always background staining in kappa lambda immunohistochemistry? It is very difficult to interpret. You are right, actually. It is only the technique. We are using milk to remove the background staining. I think you can also use milk that removes the background staining. The background becomes clear and then you can appreciate, like you saw the pictures. Those are the pictures what we are doing nowadays. Okay. Then Dr. Deepa, is there any entity called biclonal myeloma? How to diagnose it? Oh yes, there is an entity of biclonal myeloma, and a rare one in which you find that there are 2 clones of plasma cells. One are secreting IgG, another one is secreting IgA. So you will find 2 peaks. On immunofixation electrophoresis, you will come across 2 patterns of IgG and IgA. Sometimes even IgG and IgD. There are case reports. Deepa asks, is there any immunohistochemistry marker for plasma blast? Yes, CD138 and CD38, both of them pick up plasma blasts as well as plasma cells. Dr. Deepa asks how to differentiate interstitial mild infiltration of plasma cells around 10% from reactive conditions if gamma region shows a band without a spike in serum protein electrophoresis. Immunohistochemistry unconclusive for clonality. You have a case now. See, around 10% is very, very dicey. The only thing is, what we have to think of is, are we dealing with a case of smoldering multiple myeloma, or we are dealing with a overt multiple myeloma? So the clonality is the most important thing. And sometimes it so happens that the biopsy we have got is showing only one cluster where the number is coming to around 10%. If we take a biopsy from the other side, we may find that the plasma cells are many more than we had imagined or what we were thinking. So then the diagnosis of multiple myeloma becomes clear-cut. If plasma cell percentage is 40%, do we need a clonality before declaring it as plasmacytoma in every case? International Myeloma Working Group by definition says it should be 40%. We have seen reactive plasmacytosis up to 60%. So that means we can have reactive plasmacytosis up to 60%. So all more than 40% plasma cells does not mean myeloma. So we must do kappa lambda to say that these are clonal, so that first thing is the diagnosis is made. Second thing is later on, once you give chemotherapy to the patient, then you will know that it was kappa type. So next time what you are doing is you are assessing the kappa plasma cells only. Dr. Chandresh, does chemotherapy agents affect protein electrophoresis, free light chain assay? No, I don't think so, because gamma globulin area, the monoclonal antibodies will not come into that area. I don't think it should affect the free light chain assay either. But anyway, it needs to be checked up. Dr. Chetna says at places in criteria, somewhere it is mentioned 10% clonality and somewhere 60% clonality need for multiple myeloma. See, what is mentioned is the biomarkers of malignancy or the myeloma defining events. If the plasma cells are more than 60%, but then they have written plasma cells, clonal plasma cells more than 60%. So obviously it becomes a case of multiple myeloma. Suppose we have a case of 11% clonal plasma cells along with one of the CRAB features or one of the myeloma defining events, one of them, then it is myeloma, irrespective of the fact that whether it is 11% or 60%, it is myeloma. So wherever they have mentioned is 10% to 60%, they mention for smoldering multiple myeloma. But then in smoldering multiple myeloma, they have clearly said that the globulin will be more than, M spike will be more than 30, but no myeloma defining event and there will be no CRAB. For myeloma, there has to be CRAB or there has to be myeloma defining event. So we cannot go only by the number of plasma cells. Dr. Chandresh, is there any list M band present other than multiple myeloma? M band, no. Gamma globulins are increased even in Kala-Azar. You find in Kala-Azar the globulin is raised, gamma globulin is raised. That is what the plasma cells are increased and they secrete. So you will not find a M band, you will not find that sharp peak, but you will find a vague, rounded sort of raised area. That is the peak in Kala-Azar. Otherwise, it has to be a gammopathy. Now, this gammopathy will be seen in multiple myeloma. It will also be seen in Waldenstrom. And it will also be seen in various lymphomas also. Some of the lymphomas you will find is associated with M spike. In ME ratio in myeloid, do we count lymphocytes and plasma cells also? See, in ME ratio we don't count, but in every bone marrow count, we always count lymphocytes and plasma cells. Say, for example, we have done the count, erythroid are 20, myeloid are 20, ME ratio is 1:1. 50% are lymphocytes, 10% are plasma cells. If you ask me, what does it mean? It means that there is lymphocytosis, there is plasmacytosis. It could be a case of Waldenstrom Macroglobulinemia. So whenever you are counting 500 cells, don't forget to count lymphocytes and plasma cells. Do we give non-erythroid is to erythroid ratio or myeloid is to erythroid ratio. I always give myeloid to erythroid ratio because it gives us an idea to us as well as to the clinician that is myelopoiesis going on normally or not. Erythroid we also give because so that we know that is erythropoiesis going on normally or not. If we give non-erythroid, that means the lymphocytes will come in non-erythroid or non-myeloid, whatever you mean. If it is non-myeloid, various other cells will also come. It does not then convey a meaning as far as myelopoiesis or erythropoiesis is concerned. Dr. Shaini asks, can the IHC procedure of kappa lambda can be shared? We are also having background staining. Sure. I think next time when I come, I'll bring one slide and then all of you can note down from that slide. Sure, it will be done. A simple doubt. Sometimes I find it very difficult to do DC in marrow. Please explain the best method. See, in my first lecture, I explained you go to the marrow fragment in the bone marrow aspirate smear. Next to the fragment, you will find the cells are well preserved. The morphology is very well made out. The cells are discrete. You can easily count. That is the best area for you to count the various bone marrow cells. There is one last question. How do we, again from Dr. Shaini, how do we know whether decrease in erythroid series is due to actual decrease in erythroid or hyperplasia of the myeloid series? Shaini, the first thing I told you was that look at the cellularity of the bone marrow. See, there is a 60 years old man and we find that the marrow is very, very hyperplastic. And then we find that there are only myeloid cells, hardly any erythroid cells. Obviously, there is myeloid hyperplasia. And erythroid cells, if not at all seen, that means there is erythroid hypoplasia as well. So the cellularity of the bone marrow is very, very important because based on that, we will assess whether there is a decrease in one series and increase in one series. Okay. Thank you, Shiny, and thank you, everybody.